Hello, my name's Andy and I'm a nurse with Doctors Without Borders and also in the intensive care unit at Harrogate District Hospital. For the next few minutes I'm going to talk to you about my work with Doctors Without Borders and a little bit about the organisation itself. So MSF, Médecins Sans Frontières, is an organisation working in around 70 countries throughout the globe. They work in a number of different contexts and I'd like to just explore those with you if I may. First one I would look at is conflict. The pictures that you see here were taken in South Sudan in a place called Sakuri in 2008. A group called the Lord's Resistance Army had attacked our clinic, stolen medical supplies, killed 2 of our staff. This organisation has caused havoc for around 30 years in the north of Uganda, the south of South Sudan and up into the Central African Republic. We will mention them again shortly. Here's a little video about MSF's role in conflict.
In a conflict, there are many groups present: military, UN, rebels, aid organisations. All want different things. Sometimes military groups are acting like aid organisations. They run clinics and distribute food to further their own military aims. Meanwhile, some aid agencies use military resources. So where do armies end and humanitarians begin? If people think aid organisations are on one side of a conflict, we're less likely to gain access to war zones and more likely to be attacked. Médecins Sans Frontières doesn't take sides. We negotiate with all warring parties. 90% of our funding comes from private, non-government sources. This independence allows us to provide medical care in war zones like Afghanistan and Iraq right now. Our clinics are strictly weapons-free. We provide medical care based on need alone, regardless of where our patients stand. Médecins Sans Frontières, go where others don't.
The next context I'd like to look at is exclusion from care. Now this comes in a couple of different ways. The first one in the picture that you can see here is overwhelming demand. So a huge population shift outstripping the capacity of any medical system that's in existence. So that's exactly what happened in northern Uganda in 2005 when on my first mission. The pictures you see here is a place called Aloy. It's one of 6 camps. There was 50,000 people living on this camp. These are people who'd been displaced from local towns and villages, moved into this hastily established camp by the Ugandan government, and then the Ugandan army garrisoned around it to try and protect them, theoretically protect them from that group I mentioned earlier from South Sudan, the Lord's Resistance Army. The problem with this was that there was nothing in this area prior to this movement of population, and so there was no facilities for them, very little by way of medical facilities. What did exist was immediately overwhelmed as soon as these numbers started coming in. So MSF went there to provide medical care, but we also went to provide fresh water by drilling boreholes. Our water and sanitation experts got involved there, and they also got involved with working with the community to dig ventilated improved pit latrines and give the communities within the camps more secure sanitation. The opposite of overwhelming demand is where populations are very remote, and the pictures that you see here were taken back in South Sudan in 2008. And this is us trying to, in the left-hand picture, trying to access a village where we'd heard reports of measles outbreak about 4 hours away from our base facility. So a long way from any medical care. On the right-hand picture you see myself and Henry, the driver, walking through what looks like a river. This is in fact the road to one of our clinics in South Sudan. And we're just going through there to see if we're going to be able to get through. I can guarantee that we got to the clinic this day because we got there every single day of my mission, which I'm very proud of. These remote communities, one of the innovations that's happening with technology these days is the use of telemedicine. There's a short video now, a little bit about Doctors Without Borders' use of telemedicine.
Our teams travel to some of the world's most remote places to provide healthcare, even where basic resources are scarce. But how is it even possible to provide high-quality care in remote, low-resource settings? Imagine if, instead of a single doctor, our field hospitals could have an entire team of medical experts from around the world. Well, the good news is that telemedicine can make that dream a reality. At its simplest, telemedicine is about connecting doctors in one place in the world with medical specialists in another. But how does this work? In one type of telemedicine, a doctor can upload and share patient files, which are analyzed by medical specialists in other parts of the world, who then share their feedback with the team. In another type of telemedicine, doctors can discuss patient cases with specialists all over the world in live, real-time meetings. Even more importantly, our telemedicine program is providing training to doctors who work in remote places all over the world. And that means more patients can have access to high-quality medical care. As of today, we're already seeing a difference in the level of care teams of doctors provide to patients in remote places. With telemedicine, there is less reason than ever for vulnerable patients to not be able to access life-saving care simply because of where they call home. Thank you so much for watching MSF Pulse, our bi-weekly news show where we unpackage the humanitarian world. To learn more about our telemedicine program, click the link in the description.
So the next context I would look at would be epidemics, and this will be the focus of today's presentation. So we'll come back to that. Natural disasters.
Natural disasters compose massive medical logistical challenges. Take Haiti. The 2010 earthquake was catastrophic. 220,000 killed, 1.5 million homeless, 60% of health facilities destroyed, including 2 of ours. Médecins Sans Frontières quickly recruited thousands more staff, mostly Haitians, who worked in 26 hospitals, including an inflatable one in a football field. It was our biggest emergency response ever. In 10 months, we treated 350,000 patients, performing 16,000 surgeries. When cholera broke out, we treated 60% of cases countrywide. In the aftermath, 6,000 relief organisations arrived. But too often coordination focuses on their needs, not the needs of people affected. We only work with organisations who support our goal, to provide the best medical care for the patient. Médecins Sans Frontières. Go where others don't.
So now for a short time, if I may, I'd like to focus on my third mission in South Sudan. There's a very good reason for this. This gives me an opportunity to talk about the patients I've worked for on my missions in the way that I would like to talk about them. That is a very personal story with pictures of them as individuals, all these pictures of consent for them to use them in this way. But what this is going to do, hopefully, is really show you how Ebola, which will be the focus of the talk, was very difficult for me, not only to work in, but also to talk about later. So going back to South Sudan and working in the nutrition project in Leer in the north of the country, here's a young man that I worked for there, Mariak. He came to our clinic after suffering for around 2 weeks of diarrhea and probably a bit longer of poor nourishment. You can see there's a couple of things happening with him in this first picture. He's dehydrated and he's malnourished. Our focus in the original attendance was to deal with the dehydration first of all. So we reversed the dehydration, and then in the days after and the weeks after, we were starting to really work on his nutritional requirements. 2 weeks later, we've made good progress. The dehydration is completely reversed, but he is still severely malnourished. You can see that in his left arm there, which the skin is loose. He's lost all his subcutaneous fats, and he's still got a long way to go, but he's definitely going in the right direction. The same at 4 weeks, so a month down from that original attendance. He's improving dramatically, but still a little way to go. 2 weeks after that picture though, here he is at his discharge. This is 6 weeks from his original attendance, and this is what he looked like 6 weeks earlier. And this is a remarkable change and something I'm very, very proud of. The next person I'd like you to meet is Shwak. This young man came to us with a horrendous injury to his right hand, his dominant hand. He's about 15 years old, and this is a snake bite. This is a snake bite that happened around 2 weeks prior to his attendance. Now, the reason I'm showing you this isn't because it's got shock value. There is no value in shock value for me. It's not about shocking you. It's about demonstrating what remote access to medical care involves. This is what happens when people can't present at a medical facility in good time. Limbs that could have been possibly saved become unviable and have to be amputated. And that's exactly what happened to Joak. He lost his right dominant arm in our operating theatre. But look at this young man, look at his spirit. Incredible young lad who felt there was life after this. This is a picture of him with his sister, and here he is playing a game in our clinic during his rehabilitation phase. We would hope that sometime in the future, some of the technology that's creeping into the field will be able to help young men in South Sudan as it's helping people in the Middle East. And there's a short video now about the use of 3D printing technology in the field.
طلعنا نعصر زيتون وعصرنا الزيتون وروحنا. أول ما روحنا طلعنا نلعب بالحارة طخطخة. بعدين أجت الطيارة رمت برميل تفجر، أجت شظية عيدي. أجت أمي مسكت إيدي من هون عشان ما ينزلش دم وأخذتني يعني طلعتني بتدور على سيارة. بعدين حسيت إنه صار في إشي ينزل عجري. لديت عيدي كانت مقطوعة، يعني انقطعت كاملة بس ظل خيط واحد معلق بيدي. قلت لحالي يعني شو بده يصير بي هسه، يعني قلت خلاص أنا متت.
I'm Piermo. I'm the clinical coordinator of the 3D project for Doctor Without Borders here in Jordan. The hospital where we are working is a reconstructive surgery hospital, and that are patients from Syria, from Iraq, and from Yemen. Those patients are all well wounded. They are civilians for most of them, and few of them have amputations. Conventional prosthetics. It takes time, it's costly, and it needs a lot of skilled people. So it would be much cheaper to use the printer because the raw material won't cost more than $30.
So what I'd like to do now is just move on to my fourth mission in Sierra Leone. This is the Ebola mission. So first of all, just a quick recap about Ebola.
The clock ticking from the moment the Ebola virus enters the body. The disease not easy to contract, only carried in bodily fluids: blood, saliva, mucus, sweat, tears, semen, vomit, urine, or feces. And it can only enter the body through direct contact with cuts or abrasions on the skin, or through the eyes, nose, mouth, throat, or reproductive organs. People can also get infected when eating meat from or coming in contact with contaminated animals. The virus can survive several hours in a dried state on doorknobs or countertops. If the fluid remains wet and at room temperature, it can survive for days outside the body. Most people get it through contact with bodily fluids of patients or the deceased. But when is someone with Ebola actually contagious? The short answer: when they start to show symptoms. Those symptoms, though, can take from 2 to 21 days to kick in. In other words, a person could travel and interact with others for days, weeks, without passing on the virus. The average incubation period is 8 to 10 days. The early symptoms of the disease, fever, weakness, muscle pain, headache, and sore throat, are often mistaken for the flu, malaria, typhoid fever, or dysentery. But then things get worse: vomiting, bloody diarrhea, often internal and external bleeding, skin rashes, and purple spots on the skin. Once the symptoms set in, the person is contagious and has 6 to 16 days to either beat the virus or die. The death rate high, 50 to 90% chance of death depending on the strain and access to medical care. If an infected patient with a strong immune system gets proper care, the chance of surviving goes up. But if they survive, the virus could remain in the semen for up to 3 months. And if you survive, you have immunity for at least 10 years. But what's still unknown, if you're immune from other strains of Ebola. Answers and questions for a frightening disease.
So in November of 2014, I left the UK, and after some intensive training in Amsterdam, flew to Freetown in Sierra Leone. From Freetown, travelled around 200 miles across the country to the east side and a place called Kailahun. MSF had been working in Kailahun for around 6 months, and the local population had very much come to recognise our presence there as a positive thing. It's strange really that numbers play such an important part in our lives. Even numbers can stir a memory, and whenever I see the number 47, I think about Kailahun and I think about the Ebola outbreak. This is the number of people that died in the 1 month period that I was working in this outbreak. When those people died, they went to the graveyard, just down the road, about 10 minutes walk away. This graveyard was hastily established and was it was an area of cleared jungle really, as you'll see in this video. I suspect you'll recognise this appearance of people working in the Ebola outbreak wearing the PPE, the personal protective equipment, that became very synonymous with this enormous disease outbreak. We could work in the PPE that we wore there for a maximum of 60 minutes, and the reason for that is that the temperatures inside the suits were measured extremely high. And working safely in this environment for longer than that time was deemed impractical and unsafe. With that degree of discomfort inside this PPE, we had to be very efficient. And what you see in this picture is one of the medical staff planning to go into the high-risk area to do some work and briefing the team so that everyone knows exactly what they're going to do when they get inside there, so that we can be as efficient as possible as a team. Not just medical work taking place in these areas, and indeed every MSF project, also logistics work. There would be people fixing, as you see in this picture, fixing the electrics of the clinic, but also running supplies, making sure that we're getting the medications through, the vehicles are fixed, administration, paying the locally employed staff, water and sanitation, keeping the drinking water and the washing water coming to the centre. I mentioned there the national staff, the locally employed people. These are the bread and butter. These are the fundamental people within MSF. Without them, the organisation just doesn't work. There's around 30,000 of these people working globally with MSF. Now, people travelled long distances to get to our clinics, and they came across the country sometimes from near to Freetown itself. And they travelled across in these ambulances, and that's exactly what happened to this little girl, Fatimata. She travelled with a granddad all the way across the country. He was found to be negative for Ebola, while she was found to be positive. So this little girl of 2 years old was admitted to our clinic on her own because her granddad was negative. Fatimata had a very up and down journey through Ebola, but I'm afraid eventually she died. She succumbed to her illness and was buried in the graveyard that you saw earlier on in the video. It's because of people like Fatimata that I really need to tell this story, because without the story being told, it's like these people never existed, and they did exist, and they do matter. Ishmael, the gentleman that you see in this picture, he recovered from Ebola. His journey was very different. This is him at his discharge. Earlier that day, I'd taken a sample of blood from him, and we'd found that he was ready for discharge. So we walked him over to the what we called the hotel, which was our discharge area, and gave him a certificate, which is a very strange thing to do, to give somebody a certificate to say they've recovered from a disease. The reason we did this is because we wanted to show to the community that he was going to return to, that he didn't present a risk to them. So this certificate was our attempt, along with taking him back to the clinic, to the village ourselves, our attempt to try and just validate him as a completely recovered person from Ebola and no risk to the people of his community. So this was me at the end of my mission, and I left Kailahun in December of 2014 and returned home. There are technical innovations happening all the time in MSF and in all big medical organisations. One of the interesting ones that's coming through at the moment is the use of drones, and these can be used for all kinds of contexts. So, for example, to identify the location of boreholes in a cholera outbreak, so you can direct communities to where the nearest boreholes are. Things like tracking vaccines as they're rolled out, or indeed tracking disease progression as it moves from one area to another. You can figure out where you're going to concentrate your resources best to have maximum impact, looking at population movements, predicting where they're going to go, and planning the layout of large camps such as the one you saw in Aloy earlier. So there's a short video about MSF's use of drones in the field.
So you're going to go to Makanga. It's one of these areas that were affected 2 years ago.
This is the scene across almost 8
It's an area that has been cut off partially during the floods. In anticipation of what may happen, the idea is to map actually the area properly and to be able to intervene fast, to plan the resources that are needed according to the situation.
So first we need to prepare really to identify all the airfields, and after we need also to prepare the drone and all the equipment that we will need. For small areas we can use the drone, it's easier, we can fly in a lower altitude than just with aerial images, below the clouds, and we can have really precise pictures. At the end of this mission, we will have many pictures of the area. We will try just to get just one big picture of the Makanga Island. From this picture, we will try after with our GIS software just to digitalize all the access, all the roads, and try to find all the access for our missions.
Having the capacity to straight away map where the population is and to visualize that on a map allows actually to, on our side, design the intervention, and helps tremendously to communicate at a distance with the decision makers, with the actors on the ground, and to actually understand the scope of the situation and fasten the decisional process.
So thank you very much for listening to my presentation, and as I always do, I'm going to leave the final word to the people who are most important, the people that I work for, and that is of course the patients. So yeah, thank you from me and from them.